Hi, I'm Juan Frias, an endocrinologist at the University of California, San Diego, and I was asked by IDOC to give a summary of some of the events at the recent American Diabetes Association conference in San Diego, California. And what I'd like to talk about is just some of the findings, some of the data that was presented about technology. And we certainly heard a lot about insulin pumps, not only in type 1 diabetes, but also some of the benefits of insulin pumps in type 2 diabetes. There were a number of posters and oral presentations as well, focusing on continuous glucose monitoring, and again, not only in type 1, but in type 2 diabetes. And we heard a lot about next generation sensors as well, which will be more precise, more accurate as well. And very importantly, heard a lot more about the integration of these technologies, so the integration of pumps and CGM, not only from Medtronic, that's had a device for some time, but we also heard on the exhibit floor about a new device that Animas has, the Animas Vibe, which is CGM-enabled pump, basically where the pump acts as a receiver for the CGM sensor and transmitter. And as we've seen in other meetings lately, beyond the integration of these devices, what we're seeing more and more of is the automation of these devices, or the artificial pancreas or mechanical cure for diabetes, if you will. And once again, there were symposia about this topic, and clearly it's in its infancy, nothing yet approved, but studies that are ongoing looking now at how we can take both insulin delivery systems, insulin pump, the continuous glucose monitoring, and adding algorithms to this which starts automating some of the insulin delivery. Clearly something that, if it can be done safely, will be important to patients with diabetes. One device that's currently available in Europe that I want to talk in a little more detail about is MiniMed Medtronic's Paradigm Veo. And this is a system which is a CGM-enabled pump that has a low glucose suspend mode. So basically can turn off automatically at a preset glucose level in order to hopefully prevent severe hypoglycemia. And this was launched in Europe in late 2009 and is currently under FDA review here in the United States. And basically it's a system, as I mentioned, a CGM-enabled pump. From the factory, the low glucose suspend mode comes disabled, but it can be enabled by the healthcare provider and the patient to turn off at a glucose range between 40 to 110 milligrams per deciliter. So set again by the patient or the healthcare provider. It's set at a glucose suspend of 60 out of the factory when that is turned on. And basically what the device will do is alarm if the glucose hits that threshold that's set by the clinician or the patient, and then will discontinue basal insulin delivery. It does alarm thereafter, letting the patient know that that insulin has been suspended. But if the patient does not hear it or does not acknowledge this alarm, it will stay turned off for 2 hours and then resume the previous basal rate. So again, the intent here is to prevent severe hypoglycemia when glucose is low and the patient may not recognize that the glucose has hit that threshold. There was some very interesting data presented at the ADA by Francine Kaufman, the Chief Medical Officer of Medtronic MiniMed. And what they basically did in Europe was look at one-year data from CareLink, which is the software that's used by this system and other pumps of theirs. So during 2010, they looked at patients who had the Paradigm Veo system and had enabled the low glucose suspend on their system at least once. So basically there were 935 patients during this one-year period who had the system and had enabled the low glucose suspend mode. And during this time period there were 27,000 or so low glucose suspends that occurred. And for the most part these were actually acknowledged and stopped by the patient. Around 45% were canceled within 5 minutes, and another 20 or so percent were canceled within 20 minutes. So all in all, within 20 minutes of the pump stopping the infusion of basal insulin, the patients basically resumed insulin therapy as they had before. In about 10% of the patients, the low glucose suspend remained on for the full 2 hours, so the patients did not acknowledge it. And most of these, and actually many of the low glucose suspends actually occurred during the nighttime, when one would expect that the patient might not realize that their glucose is low or might not hear the alarm between 10 p.m. and 8 a.m. So one of the fears with these systems is that if the patient does not realize that it has stopped delivering basal insulin, that the patient will have extreme hyperglycemia and could become ketotic or go into DKA. And this actually wasn't seen. I mean, clearly this study was not done specifically to look at that, and we're looking at a database, so it has some limitations, which were acknowledged during the presentation. But what was seen was that the average glucose at which, in these 10% of patients where they left it off basically for 2 hours, the average glucose during the suspension of insulin was around 58 milligrams per deciliter. And they saw that in 1 hour it was about 80 milligrams per deciliter. At 2 hours of suspend it was around 100 milligrams per deciliter. And then when insulin resumed infusion, at 1 hour post resumption of infusion, it was a little over 100, and at 2 hours post it was 150 milligrams per deciliter. So the bottom line, what was not borne out here is that it did not seem to be extreme hyperglycemia with this 2 hour shutoff, or DKA with this occurring, and likely this prevented severe hypoglycemia from occurring in some of these patients. And these data really were corroborated by another abstract that was presented by Thomas Dani from Germany in children, and this has recently been published in the Diabetes Technology and Therapeutics Journal, showing that the low glucose suspend for this period of time does not lead to severe hyperglycemia or diabetic ketoacidosis. And along those lines, Medtronic is also conducting studies in the U.S. for FDA approval of this system, or that will support that submission. So I think this is a very important advance for patients with type 1 and potentially some patients with type 2 diabetes to help prevent one of the biggest fears of insulin treatment, which is hypoglycemia, particularly severe hypoglycemia that may occur during the night and go unrecognized by the patient. I think this is an important step forward, and I think getting to the ultimate goal of an automated, fully automated system, or an artificial pancreas, will take stepwise increments such as this before getting there, to make sure that it's done in a very safe and efficacious way. And as we've been seeing in meetings such as the ADA, over time now there's been more and more talk about technology in diabetes, integrating this technology and ultimately automating the technology to enable patients to improve their quality of life and have safer insulin therapy. So thank you very much. To learn more about this topic and other diabetes related topics, please visit idoc.org.